Great. Yep, Julie's recording. And oh, we have shop in Mount Sinai Morningside Hospital. Terrific. And the Van Cortlandt Jassa Older Adult Center. And many others. So great. Thank you very much. Got it here. And I'm going to start sharing my screen. Let's see, there we are. Slideshow. This over. Beginning. Okay, I think everybody can see that. Can you all see the screen? See the slides? Great, thank you very much. So welcome and to our Understanding Dementia meeting for professionals, which we hold about quarterly. And this is a good place to kind of review, and we're good. No, I'm not good.
I gotta change your view, Jed.
Oh, I gotta change my view. Oh, present your view.
Yep.
Thank you. Okay. Great. Thank you, Julie. So it's a good place, I think, for many of you. This will be a review and an update. For some of you, it'll be new information. We have 2 hours, and it's a lot of information to gather, but I think it'll be helpful to you. I'm Jed Levine. I'm the president of America. I've been at Caring Kind. Can I also ask you if you haven't please mute yourself if you're not muted already. Put yourself on mute. That would be good. If you have questions, we can use the chat feature for that. And I'll be taking periodic breaks to ask for if you have questions. So let's get started. As I was saying, I'm the president emeritus here. I was president and CEO for a couple of years. I was formerly the executive vice president in charge of programs and program development here. I've been here for almost 34 years, actually. And before that, I developed the very first adult day program in New York City. Somebody is not on mute. Who is not on mute? I sent you the outcome. I think I got that. Okay. All right. So let's continue. Now, if you are a New York State licensed social worker, you can earn 2 CEUs after you've sat through the entire presentation. I would ask you to call our helpline, and that number is 646-744-2900. Many of you use that number to sign up and request the CEU application form. You're going to have to complete a short questionnaire and then return it to us with either a check for $40 or you can call in with a credit card number if you wish. And we will be sending all participants a short evaluation form for the program, so we can learn more about kind of what else would be helpful and what we can do better. So we'll start with a basic definition, and I think even though I think people basically understand what dementia is, I think there's still a lot of confusion about what's the relationship between dementia and Alzheimer's disease and other diseases that cause dementia. Dementia is a group of symptoms, a constellation of symptoms that result from some medical condition. And there are 4 primary areas of function that are affected. One, we always think of memory as kind of one of the primary areas, both, initially short-term memory and eventually later long-term memories become impaired. But it's not just memory alone. It's all areas of cognition, thinking, planning, language, both expressive and receptive, judgment, processing information, orientation to time, place, and person. It's all of the complex mechanisms or thinking that happens as we use our brains and function in the world. So there is the cognitive component, and then there's also the kind of practical functioning, and that's how people manage their daily lives, daily activities, the instrumental activities of daily living, as well as the primary activities of daily living. But it's also affects, and many of you who are experienced in the field know this, but also personality and mood can be affected. Many people are experience apathy, kind of looks like a disinterest. It's not, might, especially not in the early stages, really is a disinterest. It's just an inability to organize themselves or to initiate activities. I see Coles has a hand up here.
Yes, thank you. I'm sorry. I do see the number that people are putting in the chat, but you put in information about the fee for the CEUs, because I was told it was complimentary.
Right. No, the program is complimentary.
Okay.
So if you're a licensed New York State social worker and you want to get CEUs, there's a $40. It's a pretty modest fee.
Gotcha. Okay.
So
thank you.
Happy to clear that up. And then in addition to the behavioral components or the behavior component, there are also progressively physical functioning changes that I think we don't often think of enough when we talk about Alzheimer's. We think of it more as being cognitive, but there are motor skills, gait changes, visual spatial function that gets impaired, reflex changes, response times, all of which, there can be balance changes in dementia as well. So it's this constellation of symptoms that define dementia. And those are further expressed in changes. Remember, some of these changes are very subtle in the early stages, in written or verbal communication, changes in problem solving and planning activities, misplacing or losing items, and certainly more frequently than normal. And I think there's a, we all misplace or lose things, but we can generally retrace our steps and find them. People who are victims of scams and are donating to, causes that might not really be causes. And the change in visual spatial ability, being able to plan how to get from point A to point B, climbing stairs, missing the step. And the visual spatial difficulties might also contribute to difficulty reading, which is why we see that, and that can happen, I would say, fairly early in some people in the disease. Other people, it happens a little bit later. Now, what can affect memory? There are so many things that affect our memory. And so what's the case for individuals getting tested? We believe that an early detection is progressively more important as there are new and interesting treatments that are going to become available and that are already available. And so certainly depression can affect memory. Sleep apnea, and there's certainly a very strong relationship between sleep apnea and memory and cognitive functioning. Metabolic vitamin issues, people with low B12 or hypothyroidism. We'll talk a little bit more about that. Vascular conditions, cancer or tumors can be detected. Somebody's changed in how they're thinking and how they're remembering. Inflammation, so many more kinds of things. I think what important one to think about is menopause, because menopause often affects women will express that they have some kind of brain fog. They're not thinking quite as clearly. They're not quite as sharp, and their memory is not quite as good. So dementia is this umbrella, and so we have a variety of causes. Alzheimer's disease is the most common cause. Vascular dementia is probably the second most common or dementia with Lewy bodies is the second most common. FTD or frontotemporal dementia. We'll go into all of these a little bit more in depth in a few minutes. Mixed And I think this is really important, that almost all cases of what we think of as Alzheimer's disease are actually to some degree mixed, that there are some elements of vascular damage, and there might be some evidence of Lewy body in the brain. But it's not just the Alzheimer's pathology alone. Malnutrition and dehydration, all of that's clearly a reversible cause. Vitamin B12 deficiency, although I will tell you, in my 40 plus years of doing this, I have rarely seen somebody cross our doors where the B12 vitamin deficiency hasn't already been ruled out and treated with vitamin B12 shots, but it's still a cause for dementia. And underactive thyroid also can be reversed with treatment. And we have, where are we? Okay. Oh, CTE is chronic traumatic encephalopathy, though that is the disease that you've heard about with football players and now with hockey players, where there is a repeated head injury and there is damage to the brain. And there is, in addition to the cognitive changes, there are also no psychiatric changes. People become, often they have suicidal ideation. They have very poor judgment about financial decisions. There are other symptoms as well. Parkinson's disease, people with Parkinson's, a certain percentage of them will experience some cognitive changes as the disease progresses. And then Down syndrome. And Down syndrome is interesting because I think it's close to 100%, if not 100%, of individuals who have Downs will develop the pathology of the disease, but not all will develop the functional decline. And there are certain, and now certainly that people with Down syndrome are living much longer and are much healthier, thanks to advances pretty much in cardiac health, that we're seeing more people living to an age when they can develop Alzheimer's disease and have the changes associated with that. Okay, now, it's important to distinguish normal aging versus dementia. And as you probably know, dementia is one of the most feared diseases, probably the most feared. Alzheimer's and other dementias are the most feared diseases of older age. Now, we all occasionally misplace our keys, our wallet, our glasses, or we leave something at home that we meant to bring with us. But the person with dementia will come to a point where they don't know what to do with that item. We all occasionally forget the right word or have trouble coming up with the right word and have that tip of the tongue sensation. But in dementia, that language impairment actually becomes more complex, and they have difficulty putting their thoughts and feelings into words and having difficulty with conversation, especially initiating conversation. And we all occasionally temporarily forget the day. Yesterday was a holiday. Today feels very much like a Monday. It's actually a Tuesday, but the difference is that when somebody has dementia, they're really losing track of the date and the season and the year. And it's more than just remembering exactly what today's date is or what the day of the week is. And I think there's a lot of research that's looking at kind of what is kind of normal aging and how do we define that and what can we normally expect in terms of cognitive changes and what can we do to help with healthy seniors to keep them as cognitively healthy as possible. So the diagnosis of Alzheimer's disease is one that's become very standardized. And so we always recommend that people go to one of the major diagnostic centers. You can certainly start with your family physician or primary care physician. Most of them, however, don't have the time and they don't have the training or the tools to do a really in-depth diagnosis. And so we refer to the major diagnostic centers, and we're very fortunate here in New York City that there are so many of them. Unfortunately, the waiting list for diagnosis can be anywhere from 6 months or more. And that's a long time in the life of somebody, especially in the stages of the disease. So the diagnosis itself is actually, the differential diagnosis is actually pretty standard. So we do a family history. They will do a full physical examination and labs, blood tests, neurological testing to get a baseline on memory, cognition, and personality, rule out any kinds of depression or other factors. And they might do some brain imaging, including a PET MRI scan or a CT scan. And there is a 90 to 95% accuracy for this clinical test, clinical diagnosis of the disease. We now have, and I'll be talking more about this later, there are some approved blood tests where you can really find a blood marker for some of the physiological hallmarks of the disease. They're not in wide use yet outside of a research setting, but hopefully they will become more available and more widely used in the next couple of months. So, and that's really one of the things that we're trying to move from kind of a clinical picture of diagnosis to a real having a very clear biomarker for the disease. And so research has made significant progress in that, and continues to work on that. So Alzheimer's disease is the most common cause of dementia, represents 60 to 80% of all dementia cases. It is a progressive degenerative disease of the brain, which causes changes in memory, thinking, language, behavior, and physical function in daily adult function. And so people need, as the disease progresses, they need higher levels of support to function and stay safe and in the world. There are 3 phases of the disease. One is a preclinical Alzheimer's disease. One is MCI, which is mild cognitive impairment due to Alzheimer's disease. And then finally, dementia due to Alzheimer's disease, which is broken down into 3 substages: mild, moderate, and severe, or progressed. And as I said earlier, the Down syndrome provides people with Down syndrome are at greater risk of dementia due to Alzheimer's disease. We don't have the 2024 numbers. These come from the Alzheimer's Association, puts out an annual facts and figures, which is always a very helpful document. And but in the 2023 facts and figures, we estimate 6.7 million Americans are living with Alzheimer's disease. And every 65 seconds, another American develops Alzheimer's disease. Notice I said develops and is not diagnosed with, because probably fewer than half of individuals with the disease actually receive a diagnosis. And it is a disease of aging. So 1 in 9 age 65 and older have Alzheimer's disease, but that number increases to 1 in 3 aged 85 and older. So once people are in their 80s, their risk of developing the disease is much greater. Alzheimer's is the 6th leading cause of death, the 5th leading cause for those age 65 and above. And it is primarily a disease of aging, as I said, but 1 to 3% are under the age of 60 or 65. And that presents its own challenges in terms of care and support for the individual, for the family, often for the adolescent children or young adult children, or sometimes even younger children who are part of the family. According to the World Health Organization, there are currently more than 55 million people who live with dementia worldwide. That is nearly the population of Spain or Korea. It is a huge number. and nearly 10 million new cases every year. This is a major global health crisis. And there have been significant work on a global level to bring this to the forefront and to advocate for more supports, more family supports, more support for the individual, as well as more support and how governments can respond. And here in the United States, we have a national Alzheimer's disease plan, national Alzheimer's plan, and that was came out in 2010 or 2011, I believe. So we were a little late to the game, but nonetheless, I think we're doing pretty well. And globally, dementia is currently the 7th leading cause of death among all diseases worldwide, and it's one of the major causes of disability and dependency among older people globally. And it's important that we recognize, and I think you all do, that the impacts of dementia are not only on the individual who's diagnosed with the disease, but also for their caregivers, for their family members, and for society at large. We have to think about how are we going to care for and provide a world also where people with dementia can thrive, where they can find meaning and purpose and connection in their lives. This is a disease, I think, that for so many is so isolating, both for that individual who has internalized the stigma against dementia and also for their family members. So I think we have a huge challenge on our hands, and I think we're meeting that challenge, but there's lots more that we can do. So by 2050, which is about 26 years away, it's not as far as it was when I started here, approximately 14 million Americans will have Alzheimer's disease. That's a huge number. And it's projected to increase to 152 million worldwide, which is nearly the population of Russia. And we estimate that 1 in 5 New Yorkers will either have or be caring for someone who has Alzheimer's disease. That's 20% of the population. Now that's if we don't find a way of either delaying the onset, preventing the disease, or even curing the disease, which I think is probably not as likely an outcome, at least in the short term. But we're actually learning so much more about ways of reducing the risk for developing the disease, and we'll talk about some of those things a little bit later. Okay. Now, to understand Alzheimer's, it's important to know some basic neurology and anatomy, which is that the brain, which is really the major organ, it's a central, it's like the CPU for ourselves. It is the organ that controls absolutely everything we do, all of our thoughts, feelings, movement, systems, and there are 100 billion neurons or nerve cells in the brain, and there are 100 trillion gaps between those nerve cells, and it's in the cells and between those cells that the pathology of Alzheimer's comes to play. And that is that there are 2 features, both one is an abnormal cluster of beta amyloid, which is a protein that builds up between the nerve cells and leads to cell death. It blocks communication between those nerve cells. And then there are the neurofibrillary tangles, which are strands of protein called tau, which are essential for maintaining cell structure. And when they collapse, that leads to cell destruction as well. So these are the 2 hallmark findings of the disease. And it's interesting that these were these were originally described by Dr. Alzheimer in 1906 when he first described the disease. And there's, his notebooks still exist. People have translated them, and his first description of a person with Alzheimer's disease is actually very would be very recognizable to you today. So when we look at the brain, comparing the brain of a normal individual on the left and the Alzheimer's brain on the right, you can see very clearly, these are age-matched samples, you can see very clearly what the differences are. Now, if we were all in the room and we could, I would ask you, but as you can see, the Alzheimer's brain is quite shrunken. It's much smaller. The gaps, the sulci and the gyri are much wider. And it just doesn't look as healthy, does it? It doesn't look as robust and healthy. There actually is brain cell destruction. And I think this is a very important photograph when we train home care workers, when we train other direct care workers, when we train family members who are, I think it's a very good depiction that there actually is, the brain is injured in this way. The brain is not as healthy as it was. And it's not because of an actual injury to the brain, it's just there is this damage that creates this shrinkage. And it's important to recognize that somebody can't do certain things because they just don't have the brain capacity any longer. And so not to blame the individual for their behavior or their repetitiveness or their need for more support, and especially around physical functioning, but to recognize that that's what's happening. And I think it's really very telling for individuals. Let me also say that I know that you're here as professionals, but that for many of you, probably half or 2/3 of you, have either cared for somebody with dementia or are concerned about somebody in your own families, or are currently caring for somebody with dementia in your own lives as well. Now, risk factors. There are so many elements that go into why people develop Alzheimer's disease, and we still, we're still learning about this, and it's a fascinating area. It's a complex interaction between our genetics and other risk factors. Actually, I remember Dr. John Rowe, who used to be at Mount Sinai, very well-known geriatrician, has written several books about aging and healthy aging, has said that only a third of how we age is determined by our genes. The rest is actually determined by our lifestyle and what we do with that genetic material and how we keep ourselves healthy. So there are certain things. So there are certain risk factors in Alzheimer's that we cannot change. Aging is the greatest risk factor. We know that people who are older are at greater risk for developing the disease, and that, and that's, aging is a healthy thing. But we want to age healthfully. Having a first-degree relative with Alzheimer's increases the risk, but doesn't determine whether you're going to develop the disease, except in very, very small percentage of families where there is an early onset genetic component. Not all early onset is genetic. And there are some people where there is a very clear genetic pattern that will determine whether they're going to develop the disease or not, or whether you have a gene that puts you at greater risk for developing the disease, but doesn't actually determine whether you're going to get it or not. We also know that race plays a factor. African Americans have double the risk for developing dementia as opposed to older whites, and Latinos are 1.5 times the risk. And this is probably not a genetic factor. It has more to do with the fact that African Americans and Latinos have higher rates of all the risk factors for cardiovascular disease. And we'll be talking more about that in just a moment. So those lifestyle factors that can be controlled are many. And it's not just one of these. And I think in some individuals, I think, we are moving now towards a world where there is much more personalized medicine, and we can determine what kind of diet, what kind of sleep, what kind of exercise is going to be best for that individual given their physiological makeup. So there are some fairly broad trends, however. We do know that heart health is related to brain health. The brain uses about 20% of the blood that's pumped by the heart. And so if there is a problem with the heart and with the cardiac system, we want to make sure that we're addressing that as much as we can. Exercise has shown over and over again to be a very strong component, and not necessarily, working out 2 hours a day, but even just getting 30 minutes of raising your heart rate, 4 or 5 times a week can be beneficial in maintaining brain health. Diet, and there are repeated, studies that show the Mediterranean-based diet, which is basically a diet where you are eating green leafy vegetables, fruits, whole grains, low-fat protein, and you have a certain amount of healthy oils and fats, and you have perhaps a glass of red wine, and you really are avoiding processed foods. You're eating foods, as Michael Pollan writes about, food that your grandmother would recognize, or maybe your great-grandmother at this point. So the American diet has led to, obesity and to higher rates of diabetes, which is also, certainly diabetes is correlated with higher risk for dementia. Which, when we talk about research, there's some fascinating things going on with insulin and insulin resistance. So the other thing is we're learning more and more about the role of sleep and the importance of sleep in terms of maintaining good brain health. We know that in healthy sleep, where you get into REM sleep, that the amyloid plaque is kind of cleared from the brain. And so amyloid is cleared from the brain, rather. And that's a good, Dr. Rudy Tanzi, who was at Harvard Medical School, and one of the world's experts in Alzheimer's disease, talks about sleep as mental floss, kind of cleaning the brain. And the old adage, you can sleep on it and you'll think about it in the morning, often is clear, because you are often clearer in the morning after a good night's sleep. Remaining socially and cognitively active and engaged. And this, there have been studies that show that people who really do something to stretch their brain, learning a new language, learning a new instrument, learning a new game, all of which is, kind of really, learning is good for the brain. And of course, managing stress. And we live in a very stressful world. We live in a world where there's a lot of stimulation. So controlling that stimulation and taking a step back, taking a breath, literally, and just managing a stressful situation, and whether that's through prayer or whether it's through meditation or whether it's through some other activity, being out in nature, all of which helps. There are also some fascinating studies that are showing the relationship of sensory issues to developing Alzheimer's disease. There's one study that shows that people who have had cataract surgery show some evidence of reducing the risk for dementia. Hearing loss, prolonged and unaided, and I'll talk to you more about that when we talk about Dr. Lin's study in a little bit. And then oral health and making sure, getting rid of the plaque and tartar on your teeth and keeping your teeth healthy and your gums healthy. There's a strong correlation with periodontal disease and tooth loss to the rate of dementia. So good oral health is an important factor as well. There's the interventions, hearing interventions.
Yes,
Yes,
sorry.
Carla, Carla.
Yes.
Yeah, I'm putting you on mute. Goodbye. Okay. So Dr. Franklin, who is at Temple University, or is he at Jefferson? One of the big medical centers, I'm sorry. I don't remember exactly where he's from, has done a lot of research into the role of hearing loss and the risk of developing cognitive decline. And his latest study in July of last year, just about 6-8 months ago, showed that hearing aid use might reduce cognitive decline in older adults who were at increased risk for cognitive decline, but not in populations who were already at decreased risk for cognitive decline. And his theory, the hypothesis, is that the strain or the demand on the brain for people who have long-term hearing loss, in order to communicate, in order to participate, in order to understand what's happening, to do the lip reading, I imagine, that actually is more of a demand on the brain, and that's why they are, without a hearing aid, with the hearing aid, it helps relieve that strain. So I think that's one of the hypotheses for why that would be. I really, before I move on, any questions so far? We've done about a half hour or so. Anything? I haven't checked the chat lately. Let me check that. Okay, I don't see anything. Oh, here's something. Well, the recording of this webinar, generally we don't share the recording of the webinar because things change over time. We do this periodically. We will be doing this again in April. So if you have colleagues who would like to join, you're welcome to do that. We will share the slides with you, however. Let's see if there are any other questions. What message? Yes, well, thank you, Irene. Irene writes that as a hearing impaired 60-year-old, I can share that wearing my hearing aids helps in being connected to others. And that's actually a really good point, because one of the other hypotheses about the why hearing loss would contribute to developing dementia is that because it does cut people off. And so socialization and engagement with others is something that's very important in terms of reducing the risk. So that's an excellent point. And why are adults with Down syndrome more at risk for dementia? I can answer that broadly by saying that there is a genetic component there, and that same genetic. Let me just say that there is a genetic component to that. I won't get into it because I don't want to misspeak, but there definitely is a role of genetics in there as well. So, all right, let's move on. Okay, so I love the slide. I think it's really important for us to think about when we think about people who are developing dementia, that cognitive changes are not an on-off switch. It's not like you get the diagnosis of dementia and then all of a sudden you're really dysfunctional. You can't manage, independent activities. It really is more like a dimmer switch. So there are going to be times throughout the disease, and I think that's important to keep in mind, where people will function a little bit higher, and then there are times that they will not be functioning as well. And remember that people with dementia are people, and they are subject to the same stresses. If they're not feeling well, if they're hungry, if they're tired, if they're cranky, if they didn't get a good night's sleep, if they're in pain. So they're not going to be thinking and functioning as well. And there is a kind of a fluctuation over, within a period of time. But with Alzheimer's disease, it is clearly always a kind of a downward slope. But it's important to remember that this is also important in terms of the ability for people with dementia who are still early in the disease and can understand when they are signing certain documents like a healthcare proxy or a power of attorney, durable power of attorney, that they have the capacity to do that. They, capacity is a legal term and is determined by the legal system. They don't need to remember it. They need to be able to understand that at the moment that they are signing that, when they're giving a power of attorney to somebody, when they're giving their healthcare proxy to a trusted family member or friend. So, and they've discussed what their wishes are. So I think I think this is an important slide for us to keep in mind. Now, how long does the disease last? The disease can last up anywhere from 4 to 5, which is rare, up to 18, 20 or more years. And the stages, we estimate that in the early stages could be anywhere from 2 to 7 years, moderate Alzheimer's 2 to 7, and again, late Alzheimer's can be 1 to 3 and even longer. But it's actually, there are many years that an individual living with the diagnosis has many years to live well, with purpose, with meaning, with engagement, with connection, given the right supports and the right opportunities. We are, the National Alzheimer's Association and the National Institute of Aging are proposing new guidelines for staging Alzheimer's disease. And as I mentioned earlier, looking more at the biologic markers, not necessarily the clinical presentation of the disease, trying to identify how much amyloid or tau, and now the more effective blood tests that have been developed and clinically validated, that will help in developing a more kind of objective way of staging Alzheimer's disease. So it's something I think that we'll see in the next couple of years, and it's very exciting. Now, one of the stages of Alzheimer's is something called MCI, or mild cognitive impairment. And MCI is where there are problems with memory and thinking that are certainly noticeable by others, but they're not severe enough to interfere with it in person's ability to live independently. It does increase the risk of developing Alzheimer's disease. But not everybody with MCI will develop Alzheimer's disease. Some will actually plateau and not decline. Some people will actually improve. And there's study trying to figure out why that is. So MCI is a fairly recent diagnostic category, I would say within the last 10 years or so, maybe a little bit longer. But it is kind of like for the most part, we can think of it as a precursor to developing Alzheimer's disease. In the early stages of the disease, here, there is short-term memory loss. There is some confusion in orientation to place and time. They have difficulty following instructions, learning new material, not impossible to learn new material, but certainly they can learn new material. And they're having difficulty with finances and money. I don't know if I remember, I don't remember if I told you that I co-led the very first adult support group for people with dementia, for early stage dementia. And 2 of our members would go out to lunch after the group before we started doing a lunch program with them. And they would talk about having a hard time figuring out what the tip was, but they still had a lot of humor, and they could connect, and they would get help from the waiter or the waitress. And it was really but it was indicative of some of that. And part of that is because it's really higher functioning cognitive activity, managing finances. So we often see that early on. Managing mail, knowing what is important and what is not, what is junk mail and what needs to be attended to. There's often a loss of initiative and motivation that can look like depression, and it might be depression, but it also is very often just people have difficulty managing these complex tasks. And so they put them off because it's kind of frustrating for them to do it. And they have difficulty performing regular tasks. And I remember seeing a client who in her kitchen had, I don't know, 5 or 6 kind of cups of tea in various stages of getting prepared. There were cups with a tea bag empty. Others, there were, just water, but no tea bag. And just had difficulty even doing something that she had done all of her life. And again, learning new routines, recognizing new people, learning the names for new people is a challenge. And there is progressively, poor judgment as the individual progresses through the early stage. Okay, well, kind of amusing comments here. Yeah, I don't look at my mail now. I think, yes, actually, you should look at your mail now. But yes, so some people actually do recover. Some people do, it's not true Alzheimer's disease. It can be one of the reversible causes of dementia. Might be medication related. It might be some underlying other problems, some metabolic problem. And poor judgment. Now, you all knew today that it was going to be cold and rainy and, freezing rain, and you all probably wore appropriate clothing if you made your way to the office. The person with dementia actually might go out in bedroom slippers or barefoot. Not so much in the early stage. That would be a little bit later in the disease. Calls?
Yeah, I was the one that said I don't look at my mail now. I better start. No, but it's making me think also what you're talking about, how a lot of times the scammers, they seem like elderly people are really vulnerable. So like listening to what you're saying here, it kind of makes sense.
They are absolutely, and financial abuse is, high on the list of things that we are concerned about with people who are cognitively impaired. And we've had many cases here where people have been taken advantage of to the tune of thousands of dollars.
Yes.
Because of their inability to determine what's real and what's not real. And it sounds good, and they're also very friendly and they're engaging, and the scammers are very good at what they do. So yeah, we've worked with the district attorney's office in each of the boroughs, who all have departments that deal with elder abuse, and there's been some really good initiatives in that area. Okay, why are we moving? Here we are. Okay. Other, early stage considerations is that we need to, the individual still has, I'm sorry, let me go back here, still has the capacity to understand what's happening to them. Now, I've heard some neurologists say probably a third of people don't want to, or not, it's not want to, that's the incorrect word, are unable to have the insight because of the cognitive changes that are happening. But the rest actually can understand the implications of the disease, and what we're doing here at Caring Kind, and what I started, back in 1990 when I was, or 91 when I did the very first support group for people with dementia, was give them an opportunity to process those feelings and share those feelings and find community. And they can also still participate in decision making, and it's a good opportunity to help people. And I'm actually working with a client who's actually in Boston at the moment, early stage, very young, and about maybe about 60, but is interested in, where are places that can take care of her if she needs the care. What are the research trials that she should participate in? So she's participating very actively in her decision making. She's still very independent. And they can still identify and articulate their feelings and put their feelings into words. And often those individuals are living independently, but they're going to need a gradual increase of support and kind of somebody to help oversee and make sure that they're doing things like opening their mail or collecting the mail from the mailbox, and making sure that, the bills and taxes are getting paid and those kinds of things. It's important for us to preserve that sense of autonomy and self-direction and self-esteem and provide the sense of dignity, and not to write somebody off, especially in the early stage. And I've heard many people in the early stage say, and I heard it recently from one of the participants in one of our early stage programs, who said, I am not my disease. I might have Alzheimer's, but I am not Alzheimer's. I'm still John, and I can still do many things, and I'm going to continue. So interesting. As the disease progresses, here the deficits become unquestionable, and there's increased memory loss and confusion, disorientation, difficulty thinking logically, organizing their thoughts, putting a plan together, what the neurologists call executive function, being able to identify a need, what steps and sequences have to be done in order to meet that need, and then what are the consequences of not doing that. There might be confabulation, which is the process of kind of making up things to fill in the gaps. Where were you today, Margaret? Well, Margaret was a teacher for all of her life. Oh, I was, had a great class today. The kids were terrific. And really wasn't what she was doing. She's just trying to fill in the gaps because she doesn't remember what she was doing, and she was filling it in with something that's familiar with her. The problems with recognizing familiar locations, why people get lost, people get confused, or if they're comfortable taking the subway independently and then they get out at Grand Central where there's a lot of construction and everybody is turned around, including me. I have to reorient myself to the changes every week. But it's recognizing those familiar landmarks, increased difficulties with communication, and again, putting thoughts and feelings into words. People can become very irritable, and very, volatile in a way. Their mood is volatile. They might have lower frustration tolerance as the disease progresses. And some might become more disinhibited and say things that they might not say in polite society, or polite company. Some people will experience hallucinations, although those are more common with certain types of dementia, which we'll talk about in a minute. And delusions. The delusions are fixed thoughts that somebody thinks is real. Like, I have to go to work, or I didn't finish that project, or they need me to play the organ at church. And it's not even Sunday, it's not Sunday morning, but they're just delusional. And they might experience sundowning, which is a very interesting and upsetting kind of syndrome where towards the late afternoon and early evening, somebody becomes more confused, more restless, more agitated. Might have to do with our own internal diurnal rhythms that are kind of disrupted, or it might have to do with the fact that if they're in a facility, often there's a shift change in the late afternoon. There's a lot of chaos, people coming and going. We actually have partnered with and are working with an organization in Phoenix, Arizona, called the Beatitudes Campus, and they have a program called Comfort Matters. We did a whole palliative care project with them, bringing the Comfort Matters approach to New York City. And they have pretty much eliminated sundowning in their nursing home, with various changes. Quite exciting. But it's can be very distressing. And there could be progressive motor problems, gait. And those of you who've ever had to help somebody with Alzheimer's or dementia into a taxi or a cab know that their sense of where their body is in space and where to put their body is a difficulty. Change, getting dressed can be a challenge. Don't know where to put their arm or their leg. And there is often in the middle stage, here you're seeing more what looks like incontinence. I don't think it's true incontinence. I think it's accidents. I think they're not responding. They have the signal that they need to go. They don't know where to go or how to manage the mechanics of toileting. And with the right support and putting people on toileting schedules, you can actually, I think, keep people continent much longer than was previously thought. As I read it out, nice comment. Several clients who need help through their mail, figuring out what actually needs attention, so they just don't read it at all, which is, I think it becomes overwhelming, and I think it becomes frustrating to them. So just get rid of it, which is not a good solution. So actually the area of incontinence and dealing with the toileting needs, it's something that's very uncomfortable for family members to do. And certainly if it's an adult child of the opposite sex, it's not something that you want to deal with, and not appropriate in many ways and for many reasons. And I think incontinence is one of the reasons, that and some of the behavioral symptoms and the sleep challenges are reasons why people will place in the long-term care, nursing home. And lastly, the middle stage here, wandering becomes more pronounced and more difficult, more challenging. We have a program that I created in 1990 that's been very successful in helping identify people who are wandering and getting them returned back home. So in the middle stages, here you want the ability still, the individual still has retained many abilities. They can participate in modified activities. They can make choices, especially if the choices are limited and they're not too many choices. And the concern is their own concern is loss of control, their frustration, their sense of abandonment, their safety. Certainly here it's no longer able to live at home. They're no longer safe being left alone at home. They're at home, they're going to need either home care or a family member to be with them because it's simply unsafe. They can turn on the faucet in the bathroom and plug it up and cause a flood in the floor below. They can turn on the gas and create a fire. They're just simply not safe, or they might be at risk for falling. And so here in the middle stage, we want to support that individual, give them choices, initiate activity, and to maintain routine and familiarity. We know that routine and familiarity are important for people with Alzheimer's disease in the middle stage. Okay. And as the disease progresses, the individual becomes progressively more dependent upon somebody else for all of their activities of daily living. And here their language becomes more impaired. There's limited verbal communication, might be just down to a few utterances. Those of you who've been in nursing homes might have heard people, say, "Mama, help me, help me." help me. And there's kind of this echo there. They're just repeating the same phrase over and over again. Minimal recognition of themselves or of family. They are more sedentary. They're not walking as often. And I think with good therapy and good rehab, and getting people up and walking, maintaining walking, you can maintain that longer again than most people think is possible. You want to avoid contractures, and keep arms and legs as mobile and as with as much range of motion as possible. There are progressive eating and swallowing difficulties, and people change diets to a kind of thickened liquid type diet or a pureed diet. And here the individual truly is incontinent. There is no control of bowel or bladder, and there is no capacity for self-care. They're totally dependent upon somebody else for all of their activities of daily living, bathing, grooming, dressing, toileting, and so forth. In those late stage considerations here, there is, I think we need to recognize and acknowledge that there is some awareness of their surroundings, and they can benefit from sensory stimulation, either gentle talk, some people, reciting a prayer together in their familiar religion. Music is a powerful tool. We have partnered over the years with an organization called Music and Memory that brings personalized music to people with dementia, even late stage dementia. And the response is astounding. There's a wonderful film called Alive Inside that documents this. And actually we helped identify some of the people who are featured in the film. And one of my colleagues, Ann Wyatt, is in that film as well. But it's using not just generally music is good, but when you use personalized music with headphones where the music goes directly into the brain, and there's no distraction of other things, and it's music that they know, and music that they know often they're during that time period of early adolescence. You're able to, I can sing every one of the Mamas and Papas songs which was part of my early adolescence, or the Beatles, or so many more. But it's different for everybody. Everybody has music that is particularly meaningful to them, especially during that time of life. So using that music, and you see people who seem completely unresponsive begin to respond, open an eye, begin to sing, move. It's really very moving. So if you can find Alive Inside, I would certainly take a look at it. It's a really great documentary. And touch, tactile stimulation, sensory aromatherapy. I think, having pet therapy, and whether it be a real pet or whether it be one of the robotic pets, it can be very helpful. And here our concerns are keeping the individual as comfortable as possible. And actually, comfort should be a goal throughout the disease, and maintaining that person's sense of dignity. You want to, and their comfort through just their physical comfort, position them regularly if they are bedbound. Provide smaller meals, finger foods, hand feeding them if necessary, and monitoring their weight, and using the palliative approach to care, which we don't have time to go into all of the particulars today, but we have some materials on our website about the palliative approach. Yes. Working with a music therapist can be very effective, but that's a very short term, it's a great thing. I've seen music therapy do wonderful, wonderful, work. But the benefit of having something that you can have a nurse's aide or a home care worker or a family member just put, somebody's music on for them. It's just that music therapist is going to be there for a half hour or 45 minutes. This is something that can be repeated throughout the day and for many days. So absolutely, I believe music therapy is a terrific tool, and I've seen it work wonders with people who've had strokes and people who've, have dementia. So, and tapping into that. And there's also the interpersonal connection, which, cannot be replaced. So I think that's, thank you for that comment. All right. I think there's room for both, is what I'm saying. Now, all right, let's get on to the just the different kinds of dementia. So I'm just watching the time here. So dementia with Lewy body is probably the second most common cause of dementia. And here, either the cognitive and memory problems similar to Alzheimer's disease, but there in Lewy body dementia, there's more likely to have initial early symptoms of sleep disturbances, visual hallucinations. I remember somebody in my early stage group who had LBD, Lewy body dementia, who would see little dogs around, and she would see, talk about little men that would be on her TV at night. And they weren't distressing to her, and she rather enjoyed the company. So, they never chose to treat that, because it was actually pleasant for her. And Parkinsonian symptoms, the tremors and muscle rigidity that's associated with Parkinson's. Robin Williams suffered from Lewy body dementia, and he was exhibiting symptoms like confusion, forgetfulness, paranoia, hallucinations, anxiety, personality changes, and difficulty with movement. He was not diagnosed until after the brain autopsy, where they found Lewy bodies in his Lewy bodies in his brain, and about 1.4 million Americans have been diagnosed with Lewy body dementia. So it's a growing issue. And again, I got these stats from the Lewy Body Dementia Association. Vascular dementia occurs as a result of small brain injuries, such as microscopic bleeding and blood vessel blockage. The location of the brain injury determines how the individual's thinking and physical functioning are affected, but initial symptoms often include impaired judgment or ability to plan and that executive functioning that we talked about. FTD, frontotemporal degeneration, includes, there are many types of FTD. Behavioral variant FTD, primary progressive aphasia, which affects language more prominently, Tick's disease, progressive supranuclear palsy, and ALS with FTD. Typical symptoms include changes in personality and behavior and difficulty with language. Here you have a picture of more apathy, disinhibition, surprising disinhibition, impulsivity, hypersexuality, hyperorality, poor financial decisions, stealing or taking things that don't belong to them, lack of insight, lack of emotional concern about how this is affecting the family members, and poor personal hygiene, which is interesting and challenging for the families. Symptoms generally develop at a younger age, and the progression is more rapid than that of Alzheimer's disease. It affects men and women equally. There are estimated 60,000 cases in the US, and diagnosis often takes longer because it's often seen as a psychiatric problem or other disease. And I think everybody is aware that Bruce Willis was diagnosed after his difficulty with language. He was having some aphasic issues. So, and again, those are from the Association for, a lot of this comes from the Association for Frontotemporal Degeneration. A lot of great information on their website as well about FTD. Just see if there's anything here. Let's see it. Okay. Oh, that's nice. Okay. Good. All right. Okay. As we talk about all of this, I think it's important to keep in mind the basic human being who exists under the cognitive and intellectual impairment. And there was a there is a bioethicist named Stephen Post, who's now the head of bioethics at Stony Brook University Medical School. Has written a lot about the ethical dilemmas of Alzheimer's disease and other dementias. And he uses the term the deeply forgetful rather than people with dementia. He thinks it's kinder and more descriptive and less pejorative. So just something to keep in mind. There are a lot of things to consider when we are working with people with dementia, and kind of who, what makes us who we are. Certainly how we think and our minds are one major component. My physical ability to do things, my mobility certainly makes me me. My sensory experiences. But with that person with dementia, we now have to think about that the now self who is dealing with these cognitive challenges and other challenges versus the then self who was fully functional. And there was a really interesting op-ed by Sandeep Jauhar, who is a physician who wrote about his dad, who I believe was also a physician who had dementia, and whether, and what kind of treatment he wanted at the end of his life. And would it make a difference if it's, him making that decision now as somebody with dementia, as opposed to somebody who executed that power of attorney, the healthcare proxy, at the time when he was, completely functional. It's really a quite interesting thought and a challenge for families to think about. Yeah. You will get the slides. So let's talk about the issue of medication and treatment, because it's an evolving story, a quickly evolving story, actually. So from 1993 to 2021, there were only symptom modifying disease treatments. There were not disease modifying treatments. And those are the ones that you're probably familiar with: Aricept, Exelon, and Razodine. Aricept's generic name is donepezil. And then there were some others, Namenda, and then there was a combination that combined the donepezil and the memantine. And again, probably, some people did not see, most people did not see dramatic improvement, but it kind of held them. And it's perhaps slowed down the progression. I'm not sure we can say that definitively, but we can say that when the treatment was terminated, there was a sharp decline in function. So clearly these weren't the best drugs, but it's what we had. And we certainly recommended that people talk to their healthcare professional about, their provider about, should they be a candidate for these drugs. So, however, almost 3 years ago now, or 2.5 years ago now, the first new drug in 18 years was approved by the FDA. It's not a pill, it's an infusion. You have to go to a center and go to get infused. It's the first disease-modifying drug approved. This is really very exciting. And I think, we can all kind of celebrate this, but I put a celebration with a little bit of an asterisk. The asterisk is that this was a highly controversial approval by the FDA. The FDA approved it under an accelerated approval, not the traditional approval, meaning they were looking at non-clinical endpoints. So we know that it removed amyloid plaque. And the thinking was, well, if you remove amyloid plaque, it's going to improve behavior, function, cognition, memory, all of that. Did it? That's not so clear. So, the other thing to think about is that this was controversial. 3 members of the advisory committee to the FDA resigned as a result of this approval, saying, one of them said it was, I'm not quoting him directly, but he said something like, this is the worst decision he's ever seen the FDA make. There just wasn't enough evidence to move this forward. However, it moved forward, it was approved. But it wasn't the end. there's still many other drugs that are being approved now, not many, but there are some drugs that are being approved now, and many hopefully down the pike. But there are also side effects to aducanumab or Aduhelm. Can cause serious side effects, including amyloid-related imaging abnormalities or ARIA, which is a rare side effect, but a serious one. It can cause brain bleeding or brain swelling. And usually it doesn't cause any symptoms, but it can be serious, and can also cause serious allergic reactions. So this CMS, which is the Center for Medicare and Medicaid Services, which determines whether they're going to pay for this, did say in April 22 that they would cover Aduhelm under this very restrictive coverage with evidence development, meaning that those, and remember, this drug is only for people who are in the early stage, that they must enroll in CMS-approved trials or trials supported by the National Institute of Health. Greatly restricted access to this whole class of monoclonal anti-amyloid drugs. And there was some discussion, and I believe that, there really was discriminatory against African Americans and Latinos who do not participate in research as much, don't have access to research trials as frequently. And again, so any new FDA fully approved monoclonal antibodies directed against amyloid will be covered, but patients need to be in a registry. So that's, now, moving forward to January of last year, the FDA approved under accelerated approval, because I said it's having a biological effect, not a clinical effect, the reduction of amyloid, a drug called lecanemab, which is being marketed as Leqembi. But 6 months later, it was approved for traditional approval. And here we have evidence that it slowed the rate of cognitive decline by 27%, and it slowed the rate of functional decline by 37%. And it was projected to delay progression to the next stage from early to middle by 2.5 to 3 years. That's really significant in the lives of people living with this disease. So it is, again, indicated only for those with the earliest stages of the disease. It's an infusion every 2 weeks. PET scan is needed to establish the amyloid burden, to make sure that the individuals have amyloid. If you want to remove it, you have to make sure it's there. And CMS finally removed the PET scan restriction. PET scans were limited to one, PET scans for amyloid were in Alzheimer's were limited to 1 per lifetime per client, per patient. And that restriction was removed just a few months ago in October. But you also need to have an MRI before the treatment and multiple times during the treatment to detect those ARIA changes that we talked about. And there are special considerations for those on blood thinners who are perhaps at greater risk for developing ARIA. Those who have a certain genetic profile are at greater risk for developing ARIA. So it's very complicated, even though this is exciting news that we now have 2 drugs that are disease modifying. One looks a little better than the other and is now under, traditional approval by CMS. But it's very, and so Leqembi did in July of last year, just 6 months ago, got this full approval. CMS approved broader Medicare coverage for those who are enrolled in Medicare and diagnosed with MCI or mild AD dementia with evidence of beta amyloid plaque on the brain. And the physician has to participate in a qualifying registry, which is not as restrictive a demand. And they recommend genetic testing, but not mandating, because those with the double A4 profile are at greater risk for ARIA. And but it also has that black box warning again for those with the double 4 profile. Okay. Now, new drug. There were new trials that came out of a drug called donanemab. And here, I'm not going to go into all of this, but they were seeing improved statistics and improved benefit. And The risk of side effects are similar to other monoclonal antibodies against Alzheimer's disease, but the symptoms were mild. And again, the benefit of donanemab is that it is a monthly infusion versus every 2 weeks. So that makes it a little bit easier for people. And then again, in July of last year, they again reiterated there were new data. Beneficial treatment effect continued to increase relative to placebo. And there was some sense that we could possibly complete treatment at 6 months. So all of which to say that we're hoping that the FDA will review this and will approve donanemab the end, in the second quarter of 2024. So by June, hopefully before. And there are other drugs in the pipeline as well. So research is actually really exciting. This is a very exciting time to talk about treatment for Alzheimer's. But keep in mind, it's only for those people with early stage. So we still have all of those, many millions of people who are living with middle and later stage Alzheimer's disease. And that this is really, just the beginning. And I heard a seminar given by the Alzheimer's Disease Discovery Foundation that Dr. Howard Phillott runs, and he's talking about, and he and others are talking about the research that's going into understanding the biology of aging. And there's a lot of work about knowing it, understanding it more fully, and what we can do to maintain healthy aging and a healthy brain. And as I mentioned earlier, there's a very strong correlation between diabetes, insulin resistance, and dementia. And study of metformin showed that there was, which is a diabetes drug, that there was a reduced risk of dementia in diabetic patients taking metformin. And so there's some trials underway combining both diet, exercise, and other lifestyle components and metformin to see if there's some synergistic effect or see what the benefit is. So stay tuned. It's actually very exciting. The bigger picture is that for every dollar we spend on research, we're spending $261 on care. That is an unsustainable equation. And the cost of dementia will exceed $1 trillion by 2050. It is the most expensive disease in the United States. There's high out-of-pocket expenses. Clinical trials are expensive. Clinical trials are going not completed because for lack of registration, lack of enrollment. So something that we're really working on here is how to get more people, especially African Americans and Latinos, enrolled in clinical trials. It takes a lot of advocacy. And there are so many other interesting things coming up. We mentioned the blood marker test, which has been approved, but hopefully will have broader applicability in the near future. Richard Isaacson, who was at New York Presbyterian Weill Cornell, did a study of clinical management of persons at risk for Alzheimer's disease. And his conclusion was that probably a third of the patients he was seeing could either delay the onset of the disease, or even if they were in the early stages, slow down the progression of the disease by a personalized approach to care and support for them. And looking at what particular type of exercise is going to be best for them, and what type of sleep regimen is going to be best for them, what kind of diet is going to be best for them given their physiological makeup. Then there's some really interesting other things going on, which we're not going to have time to talk about, because I do want to talk about something that's very close to Caring Kind's mission. And, we really are there to support both individuals living with the disease, and we have many more programs now for people in the early stage, building on the work that I did 34 years ago and more. And now, and the work of supporting caregivers and working with so many of you who are in the community and have caregiver support programs. I always say this, that if you haven't done it, I think people don't really understand what it's like to care for somebody with dementia, how exhausting it is, how draining it is, how it occupies so much of your both conscious and unconscious thought. It's always there. And so, but we also know so much more about caring for the caregiver, provide what kinds of supports are going to be best. And now we're using, thanks to a grant from the Administration on Community Living, we've introduced many evidence-based approaches to providing support, both for that individual with dementia and for their caregiver. So we know these work, and we know that people are better off for them, and their quality of life is going to improve. Their health, hopefully, is going to improve. Most dementia caregivers perform key tasks such as managing finances and communicating. I was actually overhearing a conversation the other night from a woman who was talking to a friend of mine, saying, and she's caring for her mother. She's doing all the bills. She's doing all the shopping. She's doing all the laundry. She's doing all of the appointments, and she has a full-time job, and she has a family. So it's like, it really is like another full-time job. So caregiving is, not for the weak of heart. and caregivers deserve as much support as we can give them, because they are, for the most part, family members are unpaid for the most part, and are really, providing an unbelievably important service. But they pay a toll. The toll is that there are, emotionally they pay a toll, psychologically they pay a toll. There are greater rates of anxiety, depression, more social isolation reported. Stress is higher when compared to caregivers of other diseases. There is that grief response, that chronic sadness, living in what's called the frozen grief. About a third of Alzheimer's caregivers have clinical symptoms of depression. And comparing the person with dementia with their former self is often very painful. It's hard and it hurts, and it's sad. We try to get caregivers to recognize and enjoy the person that's in front of them now, but they're human, and they're experiencing all the range of human emotions. It's not only an emotional toll, but it is a physical toll. We know that they have more doctor visits, they have greater rates of fatigue and exhaustion, reduced immune function, more cases of new hypertension and new heart disease. They're more likely to report that their health is fair or poor. They often have more emergency room visits and hospitalizations. And older spousal caregivers might predecease, the person with dementia. Let's go back. Wait. And hospitalization, or the older spousal caregivers might predecease the person with dementia. And spousal caregivers in some studies are shown to be at greater risk for dementia themselves. And I think it's just stress related, and also not taking care of themselves. Often there is very strong family conflict between between siblings and between adult children and parents. I remember one caregiver who said he felt like he was picked up by a tornado and thrown around by this disease and never knew where he was going to land. He was really concerned about, how am I going to pay for this? In this country where we have just the bare beginning of a rational healthcare system, we don't really have a rational long-term care system in place. And there is a huge workforce issue. We simply don't have enough people to take care of older adults, both in long-term care settings as well as in home settings as well, and in community settings. About 11 million Americans provide unpaid care for people with Alzheimer's and other dementias, and an estimated value of $340 billion. So we need to make a better investment in family caregivers and in paid formal caregivers as well. I'm part of the governor's master plan on aging, and these are two of the major issues that I'm involved in terms of helping to create the master plan and deal with those issues and come up with some suggested recommendations. So I'm glad the governor is working on this, has put together a really impressive team of thought leaders and individuals, caregivers, a whole wide a range of people who are dealing on this, working on creating this master plan on aging. I love this slide. So Mother Teresa, who you all know, Mother Teresa, wrote, "God doesn't give us more than we can handle. Sometimes I wish God didn't have so much confidence in me." And I think this could be any Alzheimer's caregiver who is just exhausted and thinks, and I remember speaking early when I was here many, many years ago, speaking with somebody, member of one of our support groups, who said to me, she said, every morning when I wake up and I look at my husband, I kind of hope that he will disappear because I don't know how much longer I can take this. And of course she did, with the right supports, but that feeling of just being, she's had it. I think we need to respect that that feeling and give people an opportunity to reflect and to share that feeling that they have. So it's but I think this Mother Teresa quote is really quite telling. Another woman who wrote about her caregiving for her husband, who was a Buddhist priest. Her name is Olivia Ames Hoblitzel, and she actually taught Eastern medicine at Harvard Medical School and wrote a book called 10,000 Joys and 10,000 Sorrows. This quote is from that book, a couple's journey through Alzheimer's, as she was caring for her husband. She knew she needed to live in two realities, both her reality and her husband's reality. And she also had the insight to realize that she can love him and let go at the same time. So there's this need to care for yourself and to deal with the care that your relative needs, your husband or wife or partner or parent, sibling, whatever it might be. And there's this duality that I think is very challenging for family members, because if you give all of yourself to their care, there's not going to be anything left for you and you're going to burn out, frizzle out. I think this is I love this quote. So what can you do as professionals in the field? I think one, encourage early diagnosis. So if you have the suspicion that somebody is changing beyond what is normal aging or changes, encourage an early diagnosis, especially now that the treatments and much of the research is focused on people who are really in the early or the MCI stages of the disease. So there's real compelling reason to do that now, because we do have the beginnings of treatment. Assist people with the planning, thinking about the legal, financial, and long-term care plan. Help them engage a support network, which is often very informal, family, faith-based community, other community members, and to support the quality of life, to maintain a sense of purpose and meaning for the person with dementia and their care partner, and to support a brain healthy lifestyle, and of course connect families to community resources. So until there's a cure, we will continue to be caring kind. As some of you know, that we were the Alzheimer's Association New York City chapter for over 35 years. We actually predated the National Association. We were one of the founding chapters. And back in 2015, we returned to our roots as an independent 501c3, providing free supports and services for people with dementia. We certainly work collaboratively and cooperatively with the Alzheimer's Association, but we wanted to maintain our identity as this center for care, and with our deep roots in New York City and our over 40 years of providing services. So we provide services and programs and education for people with dementia or chronic cognitive disability, for family members, partners, friends, providing care or support, certainly working with care staff, healthcare, aging, dementia service professionals, in all kinds of organizations. And all of our services are provided free of charge and are available in English, Spanish, and Mandarin, and I believe Cantonese as well. And we are New York City's trusted partner in dementia care. We have over 40 years experience. I think actually this year is our 45th year. And all of our services, as I said, are offered free of charge, thanks to our donors and supporters and foundations and grants and so on. And we certainly collaborate with many of you and your organization because we know we cannot do this alone. And we can complement each other, and we can be a resource for you as much as you are a resource for us. So we are there to provide, community awareness, provide direct service, what I call a roadmap to care and a pathway to hope, and providing well, I'll talk about the programs that I have in a moment. So the programs that we have for caregivers are, the starting point is the helpline. It's a great place. So if you know somebody who needs to get some basic information, learn about us, they can simply call the helpline at 646-744-2900. And that will connect them to us and to all of the services and supports that are available through us and through all of our partners, including many of you. We also provide one-on-one coaching services, so social work-led services, including evidence-based programs that we have integrated here. Something called Partnering Together, which is a support workshop for new or early-stage family caregivers. And we have many support groups, which I will go into in a few minutes. Just about 90 plus support groups in the 5 boroughs. We're always looking to expand our network of support groups, and we do training for support group leaders. Our support group model is a little bit different, I think, than other models. Our support groups meet either twice a month or weekly. We have very few monthly groups, and those are for specific populations for whom that's more appropriate. Or it's not as familiar to be a support group. We have specialty groups for those, for spouses, for adult children, for young onset, for Lewy body dementia, for frontotemporal dementia, and for LGBTQ caregivers. And we've been doing that LGBTQ group. We started in '93, I think, a long time ago. And we also have family caregiver workshops. We have a whole series of education programs and topical monthly webinars. And actually, our next monthly webinar is going to be on January 29th from 6 to 7:30. And it's going to be on caring for people living with dementia who are also living with dementia and Holocaust-related trauma. So those of you who are working within the Orthodox community or are providing service to that community, I think that would be very helpful to you. And you just need to call the helpline to enroll for that at 646-744-2900. Okay, so that is, again, the helpline is a place to get started. Thing I hear most from people who call the helpline is, I wish I had called a long time ago, 5 years ago. I didn't know you existed. So if you can help kind of share this information about the helpline, again, it's free of charge. And we can provide translation into over 200 languages. That actually was the heyday when we actually had people we were fully staffed in the office. We're now on a hybrid schedule. So people are coming in and out of the office. A lot of different training and dementia education opportunities. We do direct caregiver training, home care worker training, other direct caregiver workshops. And we do special programs for people with intellectual and developmental disabilities and dementia, and professional education workshops such as the one that you're attending right now. Let me see what we have in the chat. Oh, thank you. Thank you. Okay, great. Okay, thank you all. Okay, let's move on. We also have licensed master social workers who work here, provide basic counseling and support, but also help families navigate the complex and often oppositional system of long-term care that we have in this city and state and country, helping people manage the Medicaid system, which is a nightmare for most people, and also helping with family conflict assistance. We work with mediation groups when there's that kind of need. And we refer to community services for adult daycare, for home care, for other kinds of counseling and support that we don't do here. And we also have very limited special assistance funds for people where there is a specific need related to the dementia caregiving, that often for people perhaps who are applying for Medicaid and would like to go to an adult day, social adult day program and can't afford it, we can help pay that for a very short period of time, very limited funds, until they get on Medicaid. And so there are those kinds of supports available as well. Again, that's very limited. That actually should say 90 plus groups in all 5 boroughs. As I said, we have specialty groups. Our group leaders are professionally trained and supervised. So we do monthly supervision groups for our group leaders so that they can learning and the support and the experience of being in a group. They have a parallel process. So they can understand by being in a group what it's like to lead the group. And again, the group leaders, the group members benefit from this safe, welcoming environment to deal with the issues of being a caregiver and that sense of not being alone. This was a man, Ted Comet, who was a caregiver for many years and a member of one of our support groups, and wrote an article for our newsletter where he talked about how the group helped preserve his sanity, countering aloneness and despair, the only place he could openly express his pain, loss, and anger, gaining valuable insights and direction. And I remember him saying, who am I going to cry to? You know, my kids or my colleagues. He was still working at the time. I think he was in his 80s. And he said, but there's also laughter in the group. And the emotional connection and support was just, you know, priceless. One of our support group rooms, and most of our work because of COVID has moved to a virtual component like this, but we're actually doing more and more in-person programming, including in-person support groups now, which is great. We're hearing from group members who are on Zoom, they want to come back into the room. It's a different experience, and it would be different if I was in the room with you, and there would be just a different dynamic than this kind of, you know, flatness of literal of the Zoom world. It's a great workaround, but it does not replace in-person connection. I think there's something inherently human about the need to be in the room with other people. So, okay, a lot of education and training programs, new legal and financial seminars, understanding dementia, which we do for family caregivers. It's not quite as long as this. It's a little bit different focus. We do a Medicaid home care seminar regularly. I talked to you about the Monday night education meetings. The next one is going to be on living with dementia and Holocaust-related traumas. We've done them on activities and behavior and Lewy body dementia and frontotemporal dementia. And whoops. And then let me just go back. We also do more extensive training and skill building through the family caregiver workshops and the dementia care training for professionals. This is our training center, which is lovely and hopefully will be fully populated shortly. Another program that many of you might know about, which is our New York City Wanderer Safety Program in partnership with Medical Alert Foundation. Everybody who is memory impaired should be enrolled in this. It's a low-tech, high-efficiency program. We have a 99% success rate when somebody goes missing who's wearing this little bracelet. The police and EMS are all trained to look for medical identification. And so there is an initial enrollment fee, and there is an annual service fee. We will pay for that initial enrollment fee for those who can't afford it, thanks to some grants from the Charles and Mildred Schnormacher Foundation and the New York City Council and other funders, but people have to pay for that. I think it's a $39 or $49, or maybe it's $50 a year for an annual service fee. If they can't afford it, we can work something out using some of our special assistance funds, but most people many people can afford that $50 one-time annual fee. So we also have a very close relationship with NYPD and the Missing Persons Unit. We have a detective who's assigned to us and we've had detectives assigned to us since 1993 or 4, something like that. But we also have a system of proactively emailing or we used to fax them, emailing bulletins, lost patient bulletins to hospitals, shelters, EMS, police precincts, transit and medical examiners' offices when a person is discovered to be lost. So we work cooperatively with the police, and it's really been a phenomenal program. And I encourage all of you to go to our website at www.caringkindnyc.org. You know what, I've got to hold on a minute and take a look for Wanderer Safety. If you could just excuse me for 1 minute. Let me just take this, just saying. Okay, I'm gonna have to get back to them. Okay. And we do a lot of different conferences and programs. We will be doing an annual meeting, I believe, in April or March on a research update. And it's an exciting time to be talking about research, as I said. We have done meetings for chaplains and clergy over the years, and hope to redo that. We do brain health community awareness events in the Chinese community, in the African American and Latino community. And we have our fabulous Connect to Culture programs, which I think many of you are familiar with, where we work with New York's major cultural institutions, providing dementia education and how to make their programs dementia capable, working with, as you can see, a dozen or more, probably 20 now, cultural partners, including Lincoln Center for the Performing Arts and the Metropolitan Museum of Art, and MoMA, and the Brooklyn Public Library, and Botanic Gardens in Brooklyn and Queens. So it's really, it's terrific. And I encourage you to take a look at that. And again, online, you can use some of the cultural activities that we have there. So if you're working with people with dementia, you can use that as an activity. And let's see what else we have here. Diversity and inclusion are very much a very important part of what we do. They're designed to bring our programs to culturally diverse populations, including the African American, Latino, Chinese, LGBT, and most recently the Orthodox Jewish community. So we continue to expand that area. There's need. That's one of our brain health events. This is prior to COVID, probably 400 people at an event on Mott Street in Chinatown, learning about brain health. Many different early stage programs. One important one, or one that I will highlight for you, is the cognitive stimulation therapy. evidence-based small group therapy done on Zoom, and 16 sessions over 8 weeks, and then we do a maintenance program over another 8 weeks. So people absolutely love it and really get connected, and the feedback has been phenomenal. So I encourage you. Another program that I will mention to you is our MAP program, which is Memory Advocate Peers, which is pairing a trained volunteer with a family where there's a newly or fairly newly diagnosed individual and a family member, so that they can provide emotional support for them, connect them to community resources, and also encourage them to learn more about research and how to participate in research programs. Because one of the aims for that program is really to encourage more and more people to participate in research programs. So, and it's been successful. It's been kind of slow growing, actually, finding both the mentors, former caregivers who are interested in doing this work. Some are really eager to do it, and those who are doing it love it, as well as some of you, as well as getting the appropriate referrals of people who are in the earlier stages of the disease. As I mentioned to you, we have a lot of material about our palliative and residential care program. We don't have time to go into specifics about it at the moment, but I would encourage you to find out more about it by going to caringkindnyc.org/palliative care. You can read all about it. That's the Memory Advocate Peer Program. There it is again. We will be sending you this Caring Kind Connection form. So if you have clients who could benefit from programs and services that we have here, in addition to the ones that you're doing, we can, it's an easy way for you to email this back to us or fax it back to us, and we will follow up within 24 to 48 hours. And so we are all, we are privately supported, over 90% privately supported. We do a gala in June. We do our walks. We'd love to see all of you at the walk. There will be a walk again in October in Central Park. We had close to 1,000 people in the walk last October. It was terrific. And those of you who are athletes who would like to run or bike for us, or even do the triathlon for us, call the helpline and ask how to get involved with that. So thank you. Lot of sources of information for this presentation, and I thank you. I'm going to open up the chat and ask those of you who have questions. Yes, so we do. So Donna, we do provide support groups at locations, and would like to host a support group. Call the helpline, ask to speak to Suzanne, who is our Suzanne Bengston. She is the director of support services, including the support groups, and she can give you more information about that. Okay. The dementia, that there's a specific question about, thank you, about particular type of dementia attached to some with Parkinson's disease. Often I believe that it is more often a Lewy body type dementia, that there is a relationship there as well. But I believe that's true. I would have to look into that a little more before I give you a definitive answer. Yeah. Oh my, okay. Yeah, there is a need for more education generally out there. There's just a huge need for more education. And, some of you who are looking for, there was a question here about more courses and insight from us in order to be able to pass on to other carers and the families. I'm not sure what the SPECAL methodology is, so I can't comment on that. there are actually many books that are, I think, helpful. I would have to get back to you with specific recommendations on that at the moment. And so we do have, I would take a look at the website, at the education section of the website, and you'll be able to find other courses and other insights for you to take, as well as for family caregivers to participate in. And I'm going to stop sharing here. And there we are. So I think any other questions, thoughts, or comments before we end? I know it's a lot of information. You're probably like, oh my God, so thank you, everybody. Oh, how would I talk to somebody with delusions? I wouldn't argue. I would, depending upon the individual, I would kind of say, and where they are and what they're experiencing, I would kind of say, I understand that that's what you believe. But this is, what I believe. I think arguing is counterproductive. I would try to distract, get them engaged in something that's going to engage them. And I would try to get to the emotional heart of what's causing of the distress. And sometimes, like, somebody is delusional about a mother and they're missing their mother, or they, I'm waiting for my mother to pick me up. I'm waiting for my mother to pick me up. Kind of addressing that must be very painful. Tell me about your mother, and engaging them in that way. It can work or maybe not work, but I think engaging into the emotional core of what's under the distress, I think, is something that can be very helpful for some people. Other people, just asking them to help you with the task. Mary, I know you're upset, but could you help me over here with, I need help folding these socks, or something that works for her, something that talks to who she was and is going to give her that sense of connection and fulfillment. So, all right. Very nice comments here, guys. Thank you very much. All right. So we will, those of you who want the CEUs, remember you need to call the helplines and that they will give you, 646-744-2900. Ask for the CEU application. You're going to have to fill out a short questionnaire, and everybody else will get, then send us a check for $40, or you can ask to speak to somebody who can take a credit card over the phone. Okay.
Thank you.
Very good. Thank you all. Have a good afternoon. Stay dry out there and stay warm.
Thank
Great
you.
job. Great
Have a
job.
good day.
Thank you.
Bye-bye.
Bye.